Hi class, back again for part 3 of chapter 10, fluency disorders. So the warning signs, the red flags for developmental fluency disorders. Again, we're looking mostly at these between the ages of 2 and 5. They are those repetition of parts of words, either the initial sound or an initial syllable. So but, ball, or ba, ball, or cake, okay? Repetition of words or parts of words involving 3 or more repetitions. So I do it. Prolongation of a sound, so appearing to be stuck on a sound. And then feelings of frustration or embarrassment. These disfluencies are less likely to self-resolve the longer they persist. Warning signs for acquired fluency disorders. Remember, these are very rare, but they do happen. And the first one is it's almost part of its definition. There is a sudden onset of stuttering-like disfluencies. If it is psychogenic, it is caused by some significant stressor. The two other warning signs are the sudden presence of cluttering-like disfluencies, so that overuse of interjection and revision, abandonment of phrases and sentences. And the other warning sign is the inability to effectively communicate with or without frustration or embarrassment. When we're doing assessment, we have to answer 4 questions. 1, is this individual stuttering or at risk for stuttering? 2, are there any other communicative risk factors or disabilities? 3, is therapy warranted? And 4, what therapy approach is going to be most beneficial? So our assessment is going to include the following. First thing, always case history and interview. It's going to include all of the same information we've talked about before, the medical developmental kind of history, plus any history of the perception of a fluency problem and its place within this individual's life context. So are there any stressors that may be contributing? We ask parents all the time, by the way, in school when we're doing case history, have there been any recent changes in a child's life? In this case, in the case of fluency, it's very pertinent, but it also can be pertinent in language and articulation assessments, but definitely in fluency assessments. So any big changes. How has their fluency changed over time? So these case histories and interview may include the individual themselves, and they should, if this is an old enough person to be involved, parents, spouses, teachers, employers, colleagues. The second part of our assessment is going to be speech observation in a variety of situations. While we're doing this observation, we're taking data on things like the percentage of words or percentage of syllables stuttered, and noting where are they when they're speaking and who are they speaking to, what are the circumstances. Often fluency changes within settings or with partners, with whatever the circumstances are. The third part of the assessment is questionnaire and survey, to study the individual's feelings and attitudes about stuttering and communication. Also, we hand out questionnaires and surveys to parents and teachers to look into what they know about stuttering, not just about this child's stuttering, but what they know about stuttering in general. What are their attitudes and feelings about this? This is back to Scott Yarrow's assertions that the disorder of stuttering is truly best measured by the person's reactions to those feelings of loss of control. This becomes one of the most important parts of the assessment. So how is this process affecting their quality of life? And then we do direct testing. So formal and comprehensive testing, and it may include at least a screening of other areas of speech and language to rule out language or speech as stressors that are impacting fluency. There can be comorbid disorders. So a child with a fluency disorder can have a language disorder. But remember, we said previously, a language disorder in and of itself does not cause a fluency disorder. We make a diagnosis based on accumulated evidence. Now, I'm going to talk at this point more about those core and secondary behaviors than I am about the person's reaction to their moments of stuttering. So this diagnosis, things may include things like, we're going to have 4 of these, 10 or more total disfluencies within 100 words, 3 or more stuttering-like disfluencies within those 100 words, physical escape behaviors, so those are those secondary features, or verbal avoidance behaviors, also secondary features. Now, there are really 2 main commercially produced assessments for in the area of fluency. One is called the OASIS, not spelled like the oasis in the desert. It's OASES, I believe, and it was developed and published by Scott Yarus and another partner, Nina Reeves. And it's awesome. But I'm going to tell you more about one I think the book mentions called the Stuttering Severity Instrument, the SSI, and it was developed by Glendon Riley. Glendon Riley used to be the dean of our department. In fact, when I was sitting in your chairs, were we still on campus, I had Dr. Riley for a couple classes. I had him for anatomy. I had him for diagnostics, and I may have even had him for stuttering. I don't remember. But he and his wife, Jeannie, also an SLP, founded the Center for Children Who Stutter, which is housed on our campus here at Cal State Fullerton. And he produced this test, the Stuttering Severity Instrument, and it was the industry standard for many, many years, really until the OASIS came out, and it is still used quite frequently. Your book does talk about it on page 337. And we're going to talk about this assessment a little because it really still is the industry standard in terms of measuring percentage of stuttering and coming up with a severity ranking. So it looks at 3 different measurements. The first is frequency. So this is the percentage of disfluencies within 100 words. And you take, I think, 3 samples, at least 3 100-word samples of the person's speech. And count the percentage of disfluencies within those 100 words. The second measurement is to take the average of the duration of the 3 longest blocks. So you're actually timing. Is this a full second? Is it just fleeting? Is it 5 seconds? And you take the average of the 3 longest blocks, and it comes up with a number score. Frequency, by the way, also comes up with a numbered score. And then the third is physical concomitants. So those secondary behaviors that are physical. So things like eye blinks and head jerks or lip tremors or jaw tensing. And you note those, and then that also comes up with a number score. So you end up with 3 number scores, which you total, and then that gives you a ranking of severity, mild, moderate to severe, I believe, are the rankings. So the SSI, the Stuttering Severity Instrument, Glendon Riley. And I'll tell you just a quick kind of heartwarming Glendon Riley story. He and his wife, Jeannie, came to the Fluency Stuttering Conference, Fullerton Fluency Conference, there we go, every year. They were always there. They were involved a lot at the beginning with even putting it together and all of the planning, but they were at least always there. And when Dr. Riley passed away, I'm going to say 6 or 7 years ago now, I believe he passed away like in July or August of that year. And I'm sure that there was normal family memorial and, all of that. But they also held a memorial during the Fluency Conference that year. and speakers from all over the country that participated periodically in the Fluency Conference all came in for the memorial during the conference, and was very touching. So anyway, one of our own from Cal State Fullerton, Dr. Glendon Riley. Okay, treatment for people who stutter. For children, I think I've already emphasized this, but I'm going to say it again. For children, the provision of early intervention is the current professional standard. It will often involve parent implemented treatment along with direct treatment. It will definitely involve parent education. So there's a couple types of parent implemented treatment. The first is environmental modification training or models. This is training the parent to reduce the environmental communication demands and to promote fluency models in their communication with their children. So this is a lot of parent training. This is helping the parent avoid putting the child on the spot. So instead of telling the child, say it again, or slow down, or I didn't understand you, or you're stuttering, stop doing that. This is instead giving the parent language to help promote fluent speech. So, for example, one thing is to help the child know that you're listening by reflecting or repeating what they have said to you. And this is a very mental health kind of strategy. So you hear the child speak, you let them speak right through their disfluencies, and then you repeat it back or reflect it back. I think I heard you say that you really like going outside to play, and you wish that you had more time to play with your friends. So reflecting back to them, making comments rather than asking questions. So modifying activities to reduce those communicative stressors, and then using good fluency or being a good fluency model. So the use of easy talking, slowed rate of speech with pauses in your speech. Think Mr. Rogers. Mr. Rogers was the perfect example of easy talking with children. That's the model we need to give to kids, especially kids who are at risk for developmental stuttering. So reflecting, rephrasing in conjunction with that easy talking. These are environmental modifications that we can counsel parents in to help with these kids. Then there are operant training models. These models are teaching parents to identify disfluencies and to provide positive input. These promote fluent speech. They prompt self-correction. So these are allowing a parent to say things to a child, still allowing the child to exhibit the disfluencies, but then say, your speech was a little bumpy right there. So better speech might have sounded like, and then the parent can repeat what the child said. So you're identifying the disfluency, you're providing some positive input, you're prompting what fluent speech should sound like. Now, both of these models have their positive sides. I'm sure that some of you can think of the negative side of the operant training one, but however, they both do show positive impact on children's speech. And they can be used, by the way, in conjunction with each other. They don't have to be just two separate things. So those are parent-implemented treatments. Clinician-implemented treatments involve things like stuttering modification therapy. This is focusing on helping the individual to manage their moments of stuttering, to stutter more effortlessly and with less tension. The outcome of this is controlled stuttering. So back to our friend Wendell Johnson, and the Indians had no name for it. He was kind of in the forefront of developing this kind of therapy, along with a gentleman named Charles Van Riper. Charles Van Riper actually wrote my Introduction to Communication Disorders textbook And I think I was in the fourth or fifth edition of it when I was in school. So we're talking 1930s here, 1930s, 1940s, when they were developing these therapies. Um, but they are still in use today. We still use a lot of the stuttering modification, helping a person stutter more effortlessly and with less tension. The next kind of clinician implemented treatment is fluency shaping. This is designed to help the person produce fluent speech more often. I know that sounds like a better outcome, but it's not always, and it's not always possible. The goal is more frequent fluent speech. So the outcome of this is controlled fluency as opposed to controlled stuttering. And the most commonly used program here is called the LIDCOMB program, LIDCOMBE. I am not going to ask you for that name on a test. The LIDCOMB program. And it is based on operant procedures. So those of you who've had your intro to psychology and learned about operant conditioning, it uses positive reinforcement of fluency and negative reinforcement of disfluencies. Both of these approaches, the stuttering modification therapy and fluency shaping therapies, both of these approaches are effective. So that was in treating children. Treating adolescents, God bless you. These are among the toughest clinical cases. These are kids who have now obviously been stuttering for many years. Adolescents are just a hard population to work with in any case. They always think the whole world is staring at them and listening to them and judging them. And probably they have been in therapy for many years and don't want to be there anymore. Both of those therapy approaches that I described are very useful for them, but they are a tough clinical population to work with. And then adult treatment. Again, both of those therapy approaches that I described are used and both are effective. The goals of therapy at this point, regardless of age of population, is to build in knowledge about stuttering. We want to help this person understand exactly what's going on and why. And then the second goal is reduction of those negative feelings. And the third then is fluency building. And that is where we are going to stop the chapter on fluency. We will move into another video on on chapter 11 on voice disorders. I also put in titanium a list of vocabulary related to voice disorders. I will be going over it with you at the beginning of the next video. All right, see you in video 4.